Hi, my name is Raquel, and I'm doing my case study on a Baker cyst. It's also known as a popliteal synovial cyst. So there is a patient, he's a 55-year-old male. He came into the ER. He has a history of osteoarthritis. He came in because he had an acute pain on the back of his knee. The patient was afraid that he was having a blood clot. The labs came back normal. The main symptoms he had was the main pain behind his knee, and he explained it feeling full and kind of achy. So an ultrasound was ordered to rule out the blood clot. The sonographer looked specifically in the area of pain and found a large collection of fluid behind the knee, and the radiologist determined this was a Baker cyst. So the pertinent information about a Baker cyst is first the pathology. So Baker cyst forms when fluid from the knee joint escapes to form the cyst. It is thought there is a one-way valve mechanism that allows the fluid to pass into the gastrocnemius semimembranous bursa without backflow being possible. And that's what causes the big collection of fluid. Most common causes are people with arthritis, a meniscus tear, or an ACL tear. Most common symptoms are the popliteal swelling and then the posterior knee aching. Baker cysts are common, and they can be found clinically by a maneuver called the Forcher sign. This could be done at the doctor's office. So the patient will straighten their knee, and when it's straight, the doctor will feel right behind the knee, and it will feel like the bulge is firm, and when the knee is bent, it'll feel soft. This is because when the cyst is compressed between the two muscles, when the knee is extended, it gets really stiff. Etiology: most common causes of Baker cyst is arthritis or some kind of acute knee injury. Most Baker cysts are small and unilocular and located in the medial gastrocnemius semimembranous bursa. Most cause a bulge to the popliteal space behind the knee. They arise between the tendons of the medial head of the gastrocnemius and semimembranous muscle posterior to the medial femoral condyle. Sometimes the popliteal vein can be occluded because of the compression from the cyst, and this will cause lower leg edema and also can cause a blood clot. Sometimes the cyst may rupture, and this would cause the popliteal and lower leg pain and swelling and redness. So the course of the disease, if the Baker cyst is suspected, imaging may consist of just normal x-rays, an arthrogram, or ultrasound or MRI. X-ray is good for ruling out all the other common things that can be wrong with the knee, such as osteoarthritis or a break of the bone or anything like that, or inflammatory arthritis or loose bodies. An ultrasound has an advantage over MRI because it's low in cost, it's not invasive, and there's no radiation involved. MRI also has no radiation, but MRI is the gold standard because it can show so much more detail. It can also show other disorders that it could be, like a meniscal tear, synovitis, ligament tears, so much more detail, but it is more costly than the ultrasound. So the treatment procedures, if you do have a Baker cyst, if you have a Baker cyst that doesn't bug you, no treatment is necessary. If there's no vascular or neural compression, the Baker cyst that is bugging you, it shouldn't be surgically fixed for at least 6 weeks. In this time of the 6 weeks after they encounter it, they'll try rehab, which will focus on the flexibility, so it avoids that stiff feeling. They can give a steroid injection, and that can help make the cyst decrease in size, and it can also relieve some of the symptoms. There's also just good old-fashioned rest, ice, and elevation that might help. You could do an ACE bandage to compress and help. You can take NSAIDs to help with inflammation. If all that fails after the 6 weeks, you can pursue surgical treatment. And the surgery usually will focus on solely fixing the cause of the cyst. Unless the cyst is very large and has a lot of symptoms, then draining would be considered. So the prognosis is most Baker cysts will resolve on their own or with minimal treatment. Rarely will a surgery approach really be needed. So a review, Baker cysts may be symptomatic or asymptomatic. It's caused by the leaking fluid from the knee joint, and it gathers to create a bulge behind the knee. Common symptoms are acute pain, stiffness. Ultrasound is a cost-friendly way to find the diagnosis. They are caused by different types of arthritis or an acute knee injury. Treatment may include a shot, rehab, compression, and in some severe cases, surgery. I've actually seen a Baker cyst on my clinical site. It was a patient that had arthritis, had a history of arthritis, and they had pain right behind the back of their knee. They were thinking it was a blood clot. They had a history of blood clots before. We did the protocol first of going all the veins down, squishing to make sure there wasn't a clot. Then we asked her specifically where her pain was. And right when we put the transducer down on the medial knee, you could see the big pocket of fluid. And since she did have a history of arthritis, it would be a Baker cyst. I was unable to find the patient we imaged that day, so I chose to do a similar patient scenario for this case study. A differential diagnosis is there's many things that have similar symptoms as a Baker cyst. The possible diagnosis could be a popliteal artery aneurysm, ganglia, meniscal cyst, hematoma, or even a tumor. And they also have similar symptoms for a thrombophlebitis or of a blood clot as well. So those are different things that could be the same symptoms. And then here are just some of my images. The first one, this one is of a normal knee of an MRI. And then this one you can see the big cyst on the sagittal view. And this one is an axial view, and you can see the cyst right there as well. You see the collection of fluid right behind the knee joint. I loved learning about this. It was really fun. I'm excited to be able to diagnose this on my own or to see it on my own and put a note to the radiologist about the collection of fluid that was found. And here are all my sources that I did for this case study. And that's all. Thank you for watching.